today I will be talking about infectious complications of the primary immunodeficiencies. And the reason why I chose this topic is because primary immunodeficiencies are mostly diagnosed in the pediatric age group that we do not routinely get exposed to or come across. Some of these patients do present later in their adult life, and at that point, in the setting of recurrent infections, a lot of times it comes to the infectious disease physician to bring all the pieces together, and that finally leads to the diagnosis. So just wanted to briefly touch on most of the primary immunodeficiency. It's a pretty vast topic, so I tried my best to summarize as much as I could. So let's start. So primary immunodeficiencies include a variety of disorders that render patients more susceptible to infection. And a lot of these patients, if they are not diagnosed on time or if they are left untreated, these infections may even be fatal. These disorders are considered to be relatively uncommon. So far in US, about 500,000 cases have been reported, out of which 50,000 are usually diagnosed on an average each year. Most of these disorders, like I said, presents in childhood. However, they can even manifest later in life. For example, CVID, the common variable immunodeficiency disorder, that presents or that can manifest in 20s, early 20s, or even in late 20s or around 30. So these are the patients that we as adult infectious disease specialists can come across. Men and women are known to be affected equally. So I would like to first, most of this stuff, like most likely everyone knows, but I just wanted to quickly review the basics. So back to basics. T cell mediated immunity, which is the cellular immunity, as we know, limits the intracellular infections. For patients who have a defect of T cell immunity, they are more prone to viral infections, yeast infection, fungal infection, parasites, and even mycobacterium. B cell mediated immunity, which is the humoral immunity, if there is a defect with the humoral immunity, antibodies production is compromised, and that can lead to spread of extracellular pathogen and certain bloodstream infection. The one thing that needs reminder is we need to make sure we keep in mind the codependence of both the cellular and humoral immunity on each other. So if the B cell or the humoral immunity defect is identified, which is also a type of antigen presenting cell and is known to activate T cells. So clearly, if B cell immunity is compromised, it can also compromise the cellular immunity or the T cell mediated immunity, and the vice versa. So when we see defect in either cell type, it is known, and we have to keep in mind that it has a potential to affect the other line of immunity as well, whether it is cellular or humoral. And depending on what kind of deficiency it is, the kind of infection varies too. So the major subgroups of primary immunodeficiencies that I will be reviewing today includes the disorder of humoral immunity, which affects the B cell differentiation or antibody production, T cell defects, along with the combined B cell and T cell defects, phagocytic disorders, complement deficiencies, and then there are a couple of deficiencies or disorders that I have included under the miscellaneous subgroup. So first, we are going to review disorders of humoral immunity. So as we know, if there is a defect in the humoral immunity, it is secondary to either there is a defect with the differentiation of the B cell, or there may be a complete antibody production defect. There are three different disorders that collectively account for about 50% of these B cell or humoral immunity defects, which includes the CVID, which is common variable immunodeficiency, selective IgA deficiency, and Bruton's or X-linked A gamma globulinemia. Usually these patients, they present early in life, often present around 6 months of age, when the maternal antibodies are lost. And the characteristic feature is they present with recurrent bacterial infections, sinus infections, pulmonary infections, and mostly it is caused by encapsulated organisms. So before I go into the details of each of these defects, I would like to review a case here. This was a case that was published in American Society of Hematology. So let's go through it. A 46-year-old male who is a contractor by occupation, active smoker, presents with shortness of breath, productive cough, and fever. Past history includes a prior history of acute immune hemolytic anemia with consequent thrombosis and splenic infarct, which ended up requiring a splenectomy. And steroids were given in the past for AIHA. On this admission, because of the presenting complaints, a CT chest was done, which demonstrated large consolidation with posterior empyema. You can see it on the imaging on the right, that there is a pretty dense lobar consolidation that we can see, and there is also some empyema there. The collection was drained, complicated by collapsed lung, which but he recovered later. From the fluid culture that was drained, strep pneumonia was cultured, and then the patient was treated with ceftriaxone. After that, he was discharged home. 6 months later, he had a second bacterial pneumonia. And because of the history of recurrent infections, immunoglobulins were measured. There were low level of serum immunoglobulins, which included IgG, IgA, IgM. All of them were low. He had no protective titers of antibodies to any vaccines, which was again figured out on the second presentation. So at this point, I would like to stop and know your thoughts. I'm not looking for differentials. I'm just trying to, there are certain buzzwords here when it comes to the kind of clinical presentation this patient had. So just wanted to know your thoughts. What kind of primary immunodeficiency can it be? Anyone?
Is it common variable immunodeficiency?
Yes, perfect. Yes, so it is common variable immunodeficiency. So we're going to talk about it, and there were certain like buzzwords here that that can be a clue, and then we can that can help us with the diagnosis. So common variable immunodeficiency, it is characterized by defective antibody protection. The point to note is that all the IgG levels are decreased, and it's not selective defect with antibody or like with B cell differentiation or selective antibody production defect. All the immunoglobulins are low. This is the most commonly diagnosed disorder. However, the incidence is not the highest. So it's most commonly diagnosed, but the incidence is about 1 case per 10,000 to 50,000 people. Onset is usually more than 2 years of age, but can be even later in life, somewhere in the 20s. When it comes to the mechanism, so you can look on the right side in the picture. I don't know if you can see my cursor. Can you see my cursor? I'm not sure. So anyway, so with these people, usually there is a defect of the toll-like receptor, the TLR7 and 9, that finally leads into impaired plasma cell differentiation. And then the impaired plasma cell differentiation leads to impaired B cell maturation, and overall antibody production is defective. Since there is codependence, there is these patients also tend to have decreased T cell differentiation as well. So that's how we have to make sure that both the B cell and T cell lines are affected. There are 2 different kinds of CVID though. There is one of them is severe, which is the group 1, and there is not much to offer to these patients. There is no rescue therapy that we can offer. With group 2, there have been some studies where they have given interferon alpha, and that is known to help with the B cell differentiation. So that is one thing that we can offer. When it comes to CVID, there are 3 buzzwords that gives us an idea how to come to the diagnosis. So there is a markedly reduced serum concentration of all immunoglobulins. point 1. Then point 2 is these patients are known to have a very poor or even absent antibody response to immunization or any sort of infection. And then point 3 is like we have to make sure there is no other underlying immunodeficiency state. Lab findings are suggestive of hypogammaglobulinemia. So this is just like another picture. So on the left, this is the mechanism or the immune response in a healthy person compared to on the right, the immune response in a patient with CVID. So when there is any microbial organism exposure, since there is IgA deficiency, there is reduced control of the commensals, which quickly leads to translocation through the disruptive gut barrier or defective mucous membrane or like defective immunoglobulin response, so which leads to microbial translocation in these patients. And further, since all the immunoglobulins are decreased, these patients do not have an ideal immune response to the microbial translocation and eventually come in very quickly with systemic bacteremias and systemic infections. The other humoral defect that I wanted to review is selective IgA deficiency. So for these patients, the defect is in the plasma cell differentiation, and that's why they end up having a selectively decrease in the IgA production. For these patients, this is known to have selective IgA deficiency is known to have the highest incidence. There is one case per 300 to 700 persons reported, and the onset is usually later compared to CVID, more than 4 years of age. Often these patients, they remain asymptomatic, and that's why we said that most commonly diagnosed disorder is CVID and not selective IgA deficiency, because most of the patients are either asymptomatic and remain undiagnosed for a large part of their life, or maybe throughout their life. Symptoms include sinusitis, respiratory infections, GI infections, everything related to the mucosal barrier. Complications, obviously, these patients are more prone to allergies and they can even develop autoimmune diseases. And on the lab findings, we find serum IgA level, which are low. The other IgG levels or IgM level, other immunoglobulin levels, they are in normal range. The point to remember here is, in contrast to patients with CVID, patients with IgA deficiency have normal IgA response to vaccinations. And I'm going to review the vaccination guidelines later. So that is something that if we know about this, then we can just like go ahead and give them vaccinations just like any other adult. The third humoral defect I want to review is the Bruton's X-linked agammaglobulinemia. So this is in these patients, there is an absence of the Bruton tyrosine kinase gene. As you can see in the picture, there is a red box here. That's where with the defect, that's where the B cell development arrests, and the pre-B cell cannot mature further. So incidence is not determined, and usually the onset is early in the first year of age. Symptoms include recurrent bacterial infection. And again, like the serum immunoglobulins are markedly deficient or even totally absent for these patients. We have to make sure to ask for like family history in these patients if we ever come across them. Mostly these patients are diagnosed early in their age, so that is less likely, but usually family history is the clue here that differentiates it from other humoral defects. So in this table, everything is just compiled here. Just the couple of things that needs to be remembered is that in humoral defects, Haemophilus influenzae is more common among the encapsulated bacteria to cause the infection, since like most of these patients are in the pediatric age group. Among the parasites, Giardia is another one that is a characteristic one to cause the infection in these patients. Okay, so now we're going to talk about T cell defects and combined B cell T cell defects. So T cell defects is characterized by disruption of the cellular immune response. These defects are known to have more severe manifestations compared to antibody deficiencies. And affected patients, again, they present early in life with failure to thrive, and even they can have disseminated infection. DiGeorge syndrome is one of the most recognized disorders out of all the other T cell defects. So on the table on the right, it summarizes all the T cell defects that we are going to talk about. The first one is SCID. The second one is DiGeorge, Viscott, ataxia, telangiectasia. So we're going to talk about all these defects one by one. So before we do that, I want to review another case. So this is a case that was published in Pediatric On-Call Journal. It's an online platform to share interesting or unique cases. So a 7-month-old male infant born of non-consanguineous marriage presents with recurrent oral ulcers, fever, along with failure to thrive since 4 months. On the examination, he had hypopigmented macular rash over neck and perianal region. You can see it in the picture on your right. That's how the rash looked. And tonsils were absent. He also had hepatosplenomegaly. Recently, he was also hospitalized for pneumonia about 15 days back. Postnatal history was pretty benign. He was a full-term normal vaginal delivery, and birth weight was 3.1 kilogram. Family history was also pretty unremarkable. He had 2 elder sisters who were completely asymptomatic, and immunization history was again unremarkable. He was immunized till date, and milestones were normal. On the CBC, hemoglobin was low, it was 9.2. Leukocyte count was elevated to 15,000 with polymorph predominant. And he also had a lymphopenia of 2,400. Renal function, liver function was normal. Urine culture had Candida albicans. And on the X-ray chest, there was no thymic shadow. So on the right, I just used a picture here comparing the normal X-ray finding with a patient with no thymic shadow. So at this point, I would just like take a break, and I would like to know if anyone has any thoughts on what can this be, or anything at all. Like, what do you think?
I was thinking like an X-linked A-gamma globulinemia, that.
So this is the T cell defect, right?
I think with absent thymus, could it be DiGeorge syndrome?
That's a very good point. So, I mean, with the absent thymic shadow, it's very reasonable to think about DiGeorge syndrome. The only differentiating point was like he did not have like any facial anomalies or any like cardiac anomalies and all those things. So, but that's a very good point. So this patient ended up having SCID. So due to absent tonsils with recurrent infection and failure to thrive, he was suspected to be suffering from a primary immunodeficiency. And at this point, serum immunoglobulins were checked, which were actually elevated. Then the T cell CD panel was checked. And if you look at the numbers here on the downside, you can see that the CD3, CD4, CD8 T cells were all or markers were all decreased, or like these are the markers of T cells. So basically the T cells were decreased. Then the CD19 and 20 markers were normal. So these are the B cells basically. So B cell was normal. And then CD56 was low, CD16 was normal. So CD56 and CD16 is, I did not know about this before I finally worked on this presentation, but these are the markers for NK cell. So basically this patient also had like low NK cells. So finally the diagnosis of low T cell, normal B cell, and low NK cell severe combined immunodeficiency, SCID, was made. And the SCID has different subgroups, different combination of the T, B, and NK cell like defects, but this particular one is like mostly it was suspected to be X-linked. Now SCID can be like I just wanted to like go back a couple of slides. So in this table, you can see SCID can be X-linked. It can also be like autosomal recessive. The clue here was this patient's this was a non-consanguineous marriage, and then they also said that the sisters were asymptomatic. So basically, if you think about it, that's where we can make a guess that probably this is X-linked and did not manifest in the sisters secondary to that. Okay, so he was finally treated with intravenous fluconazole for the Candida albicans candidiuria and advice regarding bone marrow transplant. The other interesting point was that this patient had oral ulcers and skin rash with hepatosplenomegaly, and it was suspected to be a case of graft versus host disease due to engraftment of maternal T cells. So these kids, they are not able to fight the foreign cells, and that's what the response was. So, however, it could not be confirmed by HLA testing as parents were not willing to get tested. So let's review a couple of things about SCID. So this is a more severe form of T cell defect, and actually it's a combined defect, profound deficiency of T cell, and then B cell function is also compromised, and sometimes even the NK cell function can be defective too. 50% of the cases are X-linked and 50% are autosomal recessive, like we talked. And if you look on the right in this figure, you can see there are like certain mutations. The RAG1, RAG2, it's on the bottom, if you can see there. So RAG1, RAG2, these are the mutation in the genes, and it causes the recombination deficiency and all that stuff. So on the top, just next to the pro T cell, the development is arrested at the pro T cell stage, and for the B cells, it can get arrested at pro B cell stage. So further development of the B and T cells can get compromised in these patients. Again, there are different subgroups. T cell is always affected, but B cell and NK cell may or may not be affected depending on the kind of mutation they have. Incidence is it's pretty low, 1 case to 100,000 among 100,000 to 500,000 people. And onset is very early in the age, like less than 6 months. As soon as the maternal antibodies wane off, that's when these patients start manifesting symptoms. Lab findings are consistent with severe lymphopenia. Again, the complication we have to be aware of is a lot of times they have rashes and organomegaly secondary to GVHD because they lack the ability to reject foreign tissue, such as maternal T cell that crosses the fetal circulation in utero. Symptoms involve, these patients are very prone to develop candidemia or even mucocutaneous candidiasis, or like with this kid, he had candidiuria, which is a very early finding. And then there are certain most of the viral pathogens that are common in these patients, and they can be very frequently fatal. PJP is another one that we have to be aware of. The main thing to be cautious about is these patients should not be given live attenuated vaccines since it can lead into fatal infection. They don't have T cells to fight it back. So this was a very interesting picture I came across when I was like going through all the defects. And this is a boy in the bubble on the left upper corner. And his name is David Vetter, and he was born in 1971 with SCID. He got famous because of an experiment that was done to keep him alive. He was placed in this bubble, which was a germ-free plastic bubble. And he was later on called as the bubble boy. And then he ended up living in this bubble for about impressive 12 years. Finally, he passed away at the age of 13 in 1984. So you can see both these pictures. This is as a young kid on the top, and then the bottom picture, he has grown up into a young boy here. So that's one thing. The other T cell defect that we need to talk about is DiGeorge syndrome, which is caused by deletion in the chromosome 22. And as we know that the symptoms include the catch 22 that probably we remember it from our medical school. This happens because of the defect in the chromosome. There is an abnormal migration of third, fourth brachial pouches, which finally leads to hypoplasia, aplasia of the thymus and parathyroid glands. The symptoms include cardiac anomalies, abnormal facies, thymic absence. So that was a very good point you brought up before. Cleft palate, hypocalcemia, and again, 22 is for the chromosome 22. So that's a good mnemonic to remember. A lot of time hypocalcemia can also manifest as seizure. So something to just like as a consequence. So something to keep in mind. On the lab findings, there are reduced T cell count and hypocalcemia. These are like a couple of interesting pictures. So starting from the left top, that is a little kid with a cleft lip. Again, on the second picture, there is another kid with a cleft lip. On the right, on the top, there is a cleft palate that you can see. And on the bottom, I brought up like a couple of pictures with the heart defects. So these patients are more commonly, they have VSD, they can have tetralogy of Fallot and truncus arteriosus. See, these are the cardiac defects. These patients are more prone to develop. Then the third T cell defect we are going to discuss is Wiskott-Eldridge syndrome. This is an X-linked recessive disorder, and there is a mutation in the WAS or WAS Wiskott-Eldridge syndrome gene that encodes for the Wiskott-Eldridge syndrome protein, WASP. So on the right, if you look here on this picture, that's a very busy picture, but like on the bottom, I try to summarize how the defect impacts the B cell and T cell population. So in the patients with WASP absent, it actually impacts the formation of immunologic synapse. So where the T cell should bind the antigen presenting cells, that synapse is defective in these patients. So the T cell, basically the signaling pathway is defective. So T cell does not get activated. And this later on also, it also affects the B cell homeostasis as well due to the abnormality in T cell. So for these patients, they usually have eczema, susceptibility to infection. The other problem with these patients is that WASP is also it's also responsible for platelet dysfunction. So a lot of these patients have thrombocytopenia, and these infants present with prolonged bleeding. So the bleeding along with infection, eczema, that should be the buzzword for Wiskott-Eldridge syndrome. On the lab finding, we see thrombocytopenia and small platelets on the peripheral smear, and they are at higher risk of autoimmune disease. So these are a couple of pictures here. So you can see the petechia because of thrombocytopenia. There is some eczematous changes in the second picture. These patients have bacterial cyanopulmonary infection, and a lot of times they can also develop vasculitis. So these are the pictures. Again, on the bottom, there is another kid with eczematous changes on the leg and on the face. And on the right bottom, there is a peripheral smear which shows small platelets. And then there are also some normal platelets. Okay, and the last T cell defect that I want to discuss is ataxia telangiectasia. I'm not going to go in the details for this one because it's a very rare neurodegenerative disorder. So it's autosomal recessive. As the name suggests, it's neurodegenerative. So basically, these patients have, with the ATM gene mutation, these patients have both the B cell and T cell defects, and there is no break on the cell cycle, and later on they also develop malignant transformation because of that. So these patients have neurological symptoms. They have difficulty in walking. They are wheelchair bound by the teenage years. So if any patient, in the caveat, if it's mentioned about any sort of neurological symptoms plus infection, recurrent infection, ataxia telangiectasia should come to our mind. Okay, so these are just like a couple of other pictures. So you can, in picture A, you can see ocular telangiectasia. In picture B, this is just like some neurological defect with gait anomalies and foot drop. In picture C and D, there are some stroke or infarcted regions that you can see. And in picture E, you can see again, like there is some vasculitis changes, granulomatous changes actually. So on the skin that are more common in these patients. So this table again summarizes everything for T cell defects and combined B cell T cell defects. Yeah. Okay. So anyone, any questions so far? Anything anyone would like to say, or should I continue? All right. So the third subgroup I would like to review is the phagocytic defects. Now this is a very busy slide. I'm just going to talk about the intrinsic disorder. There are a lot of extrinsic factors that can lead to phagocytic defects, like diabetes and like autoimmune disorders and chronic splenomegaly, etc. But when it comes to intrinsic disorders, there are two subtypes. So either these patients can have phagocytic defect because of a problem with the respiratory bust, or these patients can have a phagocytic defect because of neutrophil cannot move to that place. There is a problem with the chemotaxis. So I'm going to review one disorder out of each. So you can see here there are 5 disorders under the phagocytic killing defects. Out of those, chronic granulomatous disease is the common one that I'm going to review. And then with the chemotaxis defect, I'm going to review the leukocyte adhesion defect. I've also reviewed hyper IgE later. So before we go in the details, I would like to review a case. So this was a case that was published in Frontiers in Immunology, and a full-term neonate with uneventful pregnancy presents at birth with extensive papulopustular lesions on both hands and feet, and with scattered papules with central vesicle on the body. No other abnormalities were seen. Family history was also pretty benign, except that his mother had Crohn's disease that was diagnosed at the age of 20 years. And currently she is on monoclonal antibody called vedolizumab. So this is how the lesions looked on the legs, both the legs, and it's also on the trunk. Now, the CBC was checked, which had a leukocytosis of 25,000, and there was also eosinophilia. Both immunoglobulins and lymphocyte subsets like T cells were checked. Those were normal. With the tumor markers were also checked: alpha fetoprotein, beta HCG negative. Chromosomal analysis was done, which was normal, and the blood levels of vedolizumab was checked 6 weeks after the birth, which was below the detection level. Cultures from the blood and from the skin lesions were negative. So at this point, empiric antibiotic therapy was initiated. However, there were no significant effect on the leukocyte count or the elevated CRP that this patient had on initial labs, and there were no changes with the skin lesions either. A CT of the whole body was done. We showed some multiple jagged edged cyst and axillary lymph nodes. You can see it in the picture. There are red arrows on the right top picture. And then this was further followed by MRI of the whole body. We showed bulky soft tissue masses surrounding the abdominal aorta and its branching, along with the axillary lymph nodes that we saw on the first imaging. So at this point, I would like to stop and see if anyone has any thoughts here. And I can go back to the picture if you would like.
And the B and the T cell markers are normal, so it should be like a phagocytic defect and with elevated eosinophilia. I don't know, maybe hyper IgE syndrome or something like that.
Yeah, that's a very good point. Okay, so So what the next step that they did was they actually ended up doing a biopsy of the skin and lymph node. So so here you said like hyper IgE syndrome. So when they checked the immunoglobulins, actually everything was in the normal range. So, but that's a very good point, especially with the eosinophilia. So when they did the biopsy, on the biopsy of the skin and lymph node, they found some granulomatous inflammation with eosinophilic infiltrates, and these granulomas were non-caseating. There were no atypical mycobacterium, just to let you know. And the other the important point was they also checked for a CD1 and Langerhans expression, and that was absent. So that was another characteristic point here. These are the pictures of the biopsy of the skin and lymph node, and on the right picture where you see the arrows, that arrows are actually pointing at giant cells, like multinucleated giant cells here. So additional immunological investigation was done. Basically, we had ruled out the B cell deficiencies because of this patient's immunoglobulin levels were normal, and T cell defect was also ruled out. Phagocytic defects were they were in the differential. So further testing revealed an abnormal function of NADPH oxidase, which is the main defect with chronic granulomatous disease. So eventually this patient ended up having a mutation, known to have a mutation of CYBB gene, which conferred the diagnosis of X-linked chronic granulomatous disease. Further course was, the mutation was not found in the half-brother. He was tested. Genetic testing of the mother was being planned. Several weeks later, this boy developed pulmonary granuloma due to probable invasive aspergillosis, because aspergillus infection are quite common with chronic granulomatous disease. And eventually he ended up having an allogenic hematopoietic stem cell transplant at the age of 4 months without any major complication post-transplant because of the transplant. So I'm going to just review the chronic granulomatous disease here. So this is a disorder of or defect of respiratory burst. This is the most frequently diagnosed phagocytic disorder. And males are more affected than females. It's an X-linked, or it can be an autosomal recessive form too. There is deficiency of NADPH oxidase in the phagocytes. So on the right, you can see in the picture. So when there is a defect in the NADPH oxidase, this particular component is useful or is required to develop or form reactive oxygen species, which is the main component of the respiratory burst. In the absence of NADPH oxidase, this ROS or reactive oxygen species is not formed. And then it disrupts the whole phagocytic response of the body to any kind of pathogen. So with the defect in NADPH oxidase, the elimination of extracellular pathogens is compromised in these patients. They are more susceptible to infection with catalase positive organisms, such as staphylococci, and that requires phagocytic activity for clearance. And the main thing to remember is these patients are extremely predisposed to Aspergillus infection, and mostly it's the most common cause of death in these patients. Lab findings include CD4 T cell lymphocytopenia, and when it comes to the B cell or the immunoglobulin levels, it's actually elevated in these patients. Definite diagnosis is made by the neutrophil function assay. So the main things to remember for these patients, and I think we did get a question on this on the ITE also. Nitroblue tetrazolium reduction test or the dry hydrorhodamine DHR or NBT test are the ideal tests to make the diagnosis. These are the tests that check for neutrophil function. So this was like a very good case of a patient who had chronic granulomatous disease, and this is a little kid, and it's a case of disseminated mycobacterial infection. So from A to D in the pictures, there are like scabbed lesions on different body parts, and it had like this yellowish discharge. The other thing was to note was that there was also a scalp lesion for this patient, particularly at the site of BCG administration, and they were suspecting in the case report that that's how this patient ended up developing mycobacterial infection, because it was, I think the diagnosis of CG was not made prior to that. And then in the pictures on the bottom in E, there is a large peribronchial thickening and consolidation there. On the F side, there are some lymph nodes which are enlarged with necrotic areas. In G and H, there is osteomyelitis of the left humerus and left ankle that we can see, all because of mycobacterial infection. The other defect that I want to review is the defect of motility. So leukocyte adhesion deficiencies, they are characterized by defect of motility of the neutrophils. So on the right, if you look at the picture here, there are leukocyte adhesion defect 1, 2, and 3, which are depicted here. With 1, the problem is with adhesion. And with 2, rolling is the main problem. With 3, activation is the main defect. So with 1, adhesion is the main problem. However, when any infection is encountered, in response to it, the body produces more neutrophils. So these patients actually have very high levels of circulating neutrophil. However, because it cannot adhere, it's not able to, these patients are not able to mount a good response to the infection. So that's one of the hallmark features, circulating high levels of neutrophils. The other hallmark is these patients are, because of inability for the neutrophils to reach the site where the neutrophil response is needed. These patients have delayed separation of the umbilical cord. They have recurrent bacterial infection and even poor wound healing. With leukocyte adhesion defect type 2, all these things happen. In addition to, they also might have abnormal faces and severe cognitive impairment. And with leukocyte adhesion type 3, this is the most severe form out of all. These patients are also more prone to bleeding disorders. So the diagnostic key here is the neutrophilia, that is elevated counts of neutrophil. The diagnosis is made by flow cytometry. So there are CD8 and CD11 markers on the neutrophil, which are integrin markers. And on flow cytometry, we document absence of these functional markers. CD18 can still be expressed on some of the neutrophils. So CD11 marker absence is most important to make this diagnosis. So I'm just like summarizing everything here when it comes to the phagocytic disorders for these patients. Staph aureus, Pseudomonas, and all these things are more common. Then there is a case 4. So a 20-year-old military trainee presents with fever, nausea, vomiting, headache, which started 30 hours before admission. And this patient entered at military training center 5 weeks prior to the visit. Past history includes viral meningitis at the age of 6 years. Vitals were pretty stable except a temp of 38.5. On the right, you can see there are some petechial rashes on the palms and hands. And patient was patient was normal when it comes to consciousness and orientation. There was positive neck stiffness, Kernick and Brzezinski sign that was noted. CBC had leukocytosis of 27,000. Hemoglobin was okay. Platelet was also fine. Blood chemistry was normal. A CSF study was clearly done because of the presentation, which opening pressure was slightly raised to 29. Cell count was pre-elevated. It was 3,850. Glucose was kind of on the normal or maybe like lower side, and protein level was elevated to 106. So there was also a meningococcal antigen testing that was done on the CSF, which was negative. Gram stain of the CSF did not show any bacteria. So at this point, the main reason why I wanted to discuss this case was the first thing that came to our probably everyone's mind was Neisseria meningitis infection, and that's what happened with this patient too. So the team who was taking care of this patient, they actually started her on ceftriaxone, vancomycin initially due to suspected meningitis and meningococcal sepsis. On day 2, via Vitek, the blood culture showed gram-negative diplococci, and which eventually speciated to Neisseria meningitis by day 4. So the one thing that I wanted to bring up was that sometimes like the CSF meningococcal antigen can be negative because I think it checks for certain sero groups only. The sero group was confirmed for this patient to be W135 later on. So something to keep in mind. If our suspicion is high, we still have to like keep this in our differential. CSF culture remained negative till the end, and the antibiotics were not administered before the LP was done. So finally, the patient's fever became better from day 3 of the hospital admission, and her other vital signs were stable. Therefore, only ceftriaxone was continued and vancomycin was stopped, and then she ended up completing that course. Because of prior history of meningitis, and then the second one, complement deficiency was also suspected in this patient. Radio immunoassay was done, C3, C4 was normal. However, the total hemolytic complement CH50 was low for this patient. Individual late complement component was also checked, and among C5 to C9, only C7 was very low for this patient. So there was a complement deficiency that made her predisposed to meningococcal sepsis or meningitis. She completed her ceftriaxone, and quadrivalent vaccine was given at the time of discharge. So just like quickly reviewing the complement deficiencies account for about 2% of all the immunodeficiencies. On the right, you can see the classical lectin pathway and alternative pathway. So the main goal for all the pathways is the terminal pathway or MAC activation. For classical pathway, antigen antibody binding is the main activator. For lectin pathway, it's a direct activation of the C3 convertase. And for alternative pathway, pathogen or damaged tissue is what is the activator for the C3 convertase, and finally leading to the MAC activation. Defect in classical pathway is the most common. However, the thing to remember is if anyone is having Neisseria, presents with recurrent Neisseria or pneumococcal infection, defect in alternative pathway should be considered in these patients. Indication for screening when to suspect this defect. If anyone is presenting with recurrent pyogenic infection in the setting of normal WBC and normal immunoglobulin, and if the patient has recurrent Neisseria infection at any age. So for this patient, there were already, this is the second episode of meningitis, although the prior one was suspected to be viral. And if the multiple family members are known to have Neisseria infection. So these are the certain conditions where we have to bring complement deficiency into consideration. When it comes to diagnosis with classical pathway, the main thing to remember is CH50 is the assay that is gives the diagnosis. With alternative, it is AH50, and with lactin pathway, there are deficiency of lactin-associated protease. I don't know how much of that is going to be useful for us, but just to make sure that we remember the basic test for these couple of complement deficiencies. Okay, so finally, I would like to quickly review a couple of miscellaneous infections here. So the first one, which is an interesting one, is the interferon gamma receptor antibody. This is characterized by autoantibodies to interferon gamma receptor, which impairs the IL-12 defect or signaling. And these patients are predisposed to NTM infection because of this, and they can even present with like disseminated NTM infection. There have been several case reports where it has been reported that this is more common in people coming from Southeast Asia. So if anyone is coming from Southeast Asia and they have disseminated NTM infection, and we can't figure out any other reason to have that, they are not immunocompromised or whatnot, we should be thinking about interferon gamma receptor antibody. The other infection to remember when it comes to these patients are salmonella infections. They are more prone to herpes zoster reactivation and Taloromyces moronifi. is another infection which is common in this particular patient population. The other one is Job syndrome. This is the hyper IgE syndrome, and it's a syndrome which is characterized by 3 different features. These patients have staphylococcal abscesses, sinopulmonary infection, and severe eczema. So staphylococcal abscesses is the main one. The main thing to remember here is these are cold abscesses, so they don't have like typical finding of inflammatory syndrome. The interesting point when I was reading about it was like it's called the Job syndrome based on the biblical character Job, and there is like a verse that I quoted here from the Bible that said that because like Job, the character had multiple boils as per the prior stories, so that's how this syndrome got its name. It's also called as type 1 hyper IgE syndrome, and it's an autosomal dominant defect. So with these patients, there is a JAK-STAT pathway defect, and they have basically impaired T cell response and Ig synthesis regulation defects. So T cells are low, T helper cells are low, and Ig synthesis, when it starts, these patients, their cell cycle keeps going unregulated. So that's how the Ig level goes up. So they have elevated Ig plus low T helper cell level, and then they have STAT3 defect. The other defect, which is similar to Job syndrome, is DOG8 deficiency. This is called type 2 hyper IgE syndrome. And most of the symptoms are common. The only differences are with DOG8 defect. These patients are more prone to frequent URI, upper respiratory tract infections, with eosinophilia. So that's the differentiating point. They don't have like lung abnormalities or fractures with minimal trauma and all those other systemic environment, which is seen more commonly with the autosomal dominant Job syndrome. And this one is an autosomal recessive. So these are 2 different type of hyper IgE syndromes. Then the other one is CARD11, gain of function defect. Again, this is also very rare. It is characterized by polyclonal expansion of B cells. Antibody response is impaired, basically. The main thing to remember here is these patients are more prone to pneumocystis pneumonia plus hypogammaglobulinemia. So something that should bring it to our mind if we see this combination. And the last one I have is GATA2 deficiency. This is also called monomac syndrome. Why the name monomac? Because the hallmark here is monocytopenia, so decreased numbers of monocytes, plus MAC, that is disseminated NTM infection. So monomac. So monomac is GATA2 deficiency. So I think that should ring a bell in our mind. Okay, so this just summarizes all the lab findings that we looked for in these patients. I already reviewed it with each of the defects. And then finally, when it comes to management, so the management of these patients is very critical and complicated. It's a combination of these different things that we have to offer: IVIG, bone marrow transplant. Some people are suggesting gene therapy, growth factors, antibodies, and timely vaccination. I'm not going to go in the detail of each of them. The one thing that I wanted to remember, which can be of use to us being infectious disease specialists here, is the vaccination guidelines for these patients. So quickly going through the vaccination guidelines. So this is the table that summarizes the CDC recommendation for vaccination in patients with primary immunodeficiency disorders. So the main things I have highlighted in yellow that needs to be remembered. So with humoral defects, if anyone has severe antibody deficiency, CVID, common variable immunodeficiency, or the main thing to remember is effectiveness of any vaccine is uncertain in these patients. And if these people are given IVIG, that again is another factor that can interfere with the immune response to vaccine. Contraindicated vaccines for these patients are most of the live vaccine, because With CVID, as we know, we just reviewed it, that both B cell and T cell lines are affected. So most of the live vaccines are contraindicated. So something that we need to review if we come across such patients. With less severe antibody deficiencies, all vaccines are usually effective. However, again, live vaccines is something that needs to be contraindicated, or that needs to be reviewed if it can be given in such patients or not. When it comes to T cell defect, again, we know, like with complete defects such as KID and DiGeorge syndrome, and even the partial defects of T cell production, all live vaccines are contraindicated in these patients. We can go ahead and give the inactivated vaccines because most of the time they do have B cell response. So vaccines, inactivated vaccines should be effective. But again, it depends on the degree of immunosuppression. And then specifically, one of the things that were mentioned in particular is the interferon gamma deficiency. For these patients, the one thing that needs to be remembered is live bacterial vaccines are contraindicated because they are not able to mount the response. And especially we reviewed that patient where like they can have disseminated mycobacterial and disseminated infections. So something to keep in mind. When it comes to complement deficiencies, all routine vaccinations are likely effective. There is no contraindication. For phagocytic defects in chronic granulomatous diseases, again, live bacterial vaccines are contraindicated. Live viral vaccines are pretty good. Inactivated vaccines are also okay to give. With phagocytic defects, all inactivated vaccines should be okay, but we do avoid the live vaccines for these patients as well. So these are my references, and thank you so much for giving me your time. I would be open to any questions or anything you would like to add.